Stay tuned. Video unavailable. All right. Make a note of that, Haritha. Don't know why. There we go. Oh, I just declined something of yours, Paul. I don't know what that was. Sorry.
No, that's fine.
Okay, there we go. Hello, everyone, and welcome to Bright Spots in Healthcare. We are produced by Bright Spots Ventures. Bright Spots Ventures is dedicated to accelerating innovation through content, communities, and meaningful connections. Our mission is pretty simple. We spotlight what's working in healthcare and help understand what those successes are so that you could all scale them. We bring leaders together from health plans, hospitals, and other healthcare innovators around the land to share proven strategies that drive measurable impact. And through our podcast and webinar, our executive councils, our private events, and our go-to-market strategy work, we surface and amplify these bright spots in healthcare, proven innovations that others can learn from and replicate. We love what we do, and at our core, we exist to foster trusted relationships that fuel real progress. And because we believe the best way to improve healthcare is to find what's working, a bright spot, and clone it. If you have not subscribed to Bright Spots in Healthcare, we encourage you to stop what you're doing right now and click on the podcast app that you most enjoy and type in Bright Spots in Healthcare and get weekly shows downloaded to your device with all these great leaders offering you great advice, like the aforementioned, like this incredible guests list that we have for you today. Real quick, we're really excited to welcome in a new partner to the Bright Spots family. That organization is called Smart Story. They are a digital engagement platform purpose-built for healthcare. They are led by a former Blue CEO, and they help health plans around the land move beyond those generic reminders and outdated outreach by delivering secure, personalized content during high-value moments in a member's care journey. Check them out at smartstory.com. Well, I'm talking right now, but I'm going to actually bring them back and talk about them a little bit more later on during the episode. So, our panel today, I want to introduce them all. We'll put their bios into the show notes on your podcast app, or if you're watching live via Zoom right now, we'll put that into the chat. The aforementioned CEO of Smart Story, Paul von Ebers, is here. He is, like I said, a former CEO of a Blues Plan and now the CEO of Smart Story. We're also joined by Daniel Weber. Dan is the Senior Vice President of Stars and Quality at Zing Health. And last but certainly not least, Athena Patrikios. I was scared to say her last name, practiced before the show. That's why she went last. I was gearing up for it. Sorry, Athena. She's the Director of Pharmacy Medicare at Horizon Blue Cross Blue Shield of the great state of New Jersey. We're going to talk about how these organizations are using innovations and stories to drive star ratings and better adherence. We're calling the episode Lights, Camera, Adherence. Yes, right. That was my creative idea. It's like a mini series, Lights, Camera, Adherence. We know that adherence is playing such a big role now in everyone's star ratings. You guys are moving beyond, everyone listening, beyond those one-size-fit-all reminders. So we're going to talk a lot about today as we get more personalized, story-driven, and inspire real behavioral change. Today, we're going to explore how leading organizations are blending that data and the behavioral insights along with creativity to improve medication adherence and enhance overall consumer experience and drive those measurable gains that are so needed as we look ahead to the 2026 performance year. So we've divided the show into 3 segments. We're going to start with a segment we've entitled Strategy Shifts and Organizational Mindsets. A quick PSA too. You guys can help me moderate, as I often encourage you to do if you're live watching on Zoom. And you could do that via the Q&A module. Do not use the chat. or our producer's going to yell at you. Wakanda doesn't like people. No, I don't like people using the chat because as the questions come in, I like it gets disorganized. The Q&A module allows us to see those questions and then answer them accordingly. We'll do the best we can through typing and through interrupting the show to get to as many questions as we can as possible. We do have a pretty tight schedule, but I think there'll be a little bit of room. So let's start with strategy shifts and organizational mindset. I'm going to bring in Dan Weaver first. He's the SVP of Stars and Quality at Zing Health. So Dan, Part D adherence challenges. What is Zing Health's approach to building an organization and a structure within that organization that can effectively address the many barriers standing in your way? And I guess I'll ask you the quick favor for those who don't know Zing Health, that just give a quick 411 on who you are and then how you guys are approaching these many barriers through an org structure.
Okay, great question. So Zing Health is still a relatively new entry into the Medicare Advantage space. Been around about 4 or 5 years, predominantly serving chronic special needs membership, based out of Illinois with membership in Michigan, Indianapolis, Memphis, Cleveland, kind of spread out across a wide variety of locations, if you will, geographies. Um, so that in and of itself actually helps present some really interesting challenges. Um, building the structure for the organization, is interesting when you're a startup, because, you are always trying to do more with less. You're, balancing all of the crazy overhead costs against, building an organization. So it's like the old analogy of, you're still building the plane while you're trying to fly it. Um, as far as like building an organization that's really targeted toward addressing and overcoming barriers, the first thing I'd say is we take an approach of sort of sprinkling in solutions. I've always firmly believed there's no one silver bullet when it comes to anything within the Medicare Advantage like star rating landscape, but especially within medication adherence. I've had the opportunity in my career to work with, white collar retirees. I've worked with, employer group folks that have transitioned over. I've worked with D-SNP membership, that mirrors some of the C-SNP membership we see a little bit more, Medicaid, et cetera. And everybody's issues are just variations of sort of, couple of sort of generic barrier challenges. So we have taken the approach of effectively, building an organizational structure that supports trying to tailor those solutions to the right type of barrier solution mitigation, if you will, as it comes up. So we tend to focus on engagement, whether that's with our provider base, whether that's with our pharmacy partners, whether especially around our membership itself. So there's a lot of, telephonic, but we do things like point of sale nudges, really coordinated communications, multi-platform communications. I think kind of leading into what I heard you say about Smart Story, right? We're trying to hit the people at the right time with the right type of messaging in a meaningful way. So, we kind of focus in on resolving those barriers one by one, not assuming that everybody just fits neatly into some bucket, but really assuming that there has to be some level of customization to that member. There's going to be a tool in our tool belt that's going to help them, and that tool is going to be different for Dan than it's going to be for Athena, than it's going to be for Paul, than it's going to be for Eric. And we kind of cover, I guess, the spectrum of the standard solutions, if you will, that are kind of widely accepted. A lot of times you're trying to move members to an extended day supply if maybe transportation's a barrier, or if it's, an issue, with delivery frequencies or whatever. There can be a variety of reasons you use extended day supply. It's less trips to the pharmacy, less times they have to remember to go get a refill, all that fun stuff. Cost is always one of the core barriers that pops up. So, trying to find the creative ways to solve that. Most plans have done a pretty good job of making the measures that are in the medication adherence measure, or sure, I should say the drugs that are within the medication adherence members, inexpensive or free. But people still run into challenges, still have some, co-pays, things like that that you have to address. Transportation is always a big one. especially for Zing, our membership tends to be pretty rural. I'm sorry, not pretty rural, pretty urban. We really focus in on, underserved populations in dense urban areas. So you've got public transportation, but all of those come with their schedules and their own challenges. You've got people that have disabilities. So, each individual person who may have a transportation barrier also has a variety of needs within that space. And then you've got things like side effects, right? Somebody's taking a drug and it's a newer drug and they get a weird interaction, or they went into the hospital for some stay, they got put on something as a temporary fix, and now they're having an issue and they decide, oh, I don't need to take my hypertension medication anymore, or I'm not supposed to take my diabetes med because the doc told me to do this, which always leads us into member education.
Mhm.
Everybody's place is different. You never want to assume that people heard their doctor correctly when they met with them and were given the information they were supposed to about their drug, that the local pharmacy is able to take the time to counsel them and make sure they understand how to take it appropriately and what to look for, when they should and shouldn't, tips and tricks on how to make sure you remember. So I'd say that we take that full spectrum, Eric, and really try to make sure that when you're talking to Dan, you can identify what Dan needs. And you've got all the tools in your tool belt to be able to say, okay, well, this is the thing that I need when I'm working with Dan. So let's pull this one out and let's solve Dan's problem, knowing that again, that's going to be a little bit different than the next person you talk to.
So almost dividing your strategy up by creating almost personas based upon the barriers that you got to resolve for each individual member that you're engaging with, and
Yeah, that's
and you're almost using like a whole team, a holistic approach to getting them to the right solution.
that's very fair.
So I'm gonna head down now to New Jersey, and I'm in New England, so it's heading down to New Jersey. So Athena Patrick Kios is the head of pharmacy Medicare at Horizon Blue Cross Blue Shield. When you're seeing like what are you as we see sort of this evolution of technology, evolution of how we use data, what are some of the biggest shifts in overall strategy or mindset that has helped Horizon Blue Cross Blue Shield kind of transform how you approach Medicare medication adherence, and what's that done for your star ratings?
Sure. So, I mean, I think our biggest shift in strategy really happened back in 2018 when we moved from a vendor managed model for medication adherence into internal. And we built a really strong core team that enables a high touch approach, which leverages a lot of the basic data that we have access to, but really takes it to the next level. So we manage and track date of refills, days supply, the date that by which member needs to fill, whether they're engaged in case management, are they in our medication therapy management program, and when they've had an appointment with their doctor last, and when we think they might need a new prescription. So some of that basic information, and we really built a great and really hardworking core team of pharmacists and technicians that leverage that data and really target members in a very, it's targeted in that it's not a one size fits all, as Dan mentioned. So based on the information we have access to, we're leveraging that information and really having that custom one-to-one conversation. It also has allowed us, by being sort of really engaged in the process, that deeper involvement in the data, as well as the performance tracking and outreach. We also have, in addition to our core team, we leverage the extended team within the organization. So we work very closely with our quality management teams, our case management teams, our provider partners to help us outreach members and close those gaps. We also are a sixth-year pharmacy student rotation site. So students have the opportunity to help research and support our core team in doing those outreaches, as well as residents. So we have a pharmacy residency program in-house, and so they also contribute very significantly to the program. We also leveraged our collaboration with our PBM and help build the reporting that we get today through the PBM, and that has also helped support our team's ability to perform that high touch intervention and drive the accountability as well. And overall, we've seen our movement to adherence scores of 4 and 5-star performance for the last several years across all 3 measures for the STAR program. And our Part D domain overall has been around 4.5 stars pretty consistently. So we've done a lot with that in-house program.
Wow, that's great. So high touch, deeper involvement in the data, bringing a lot of people in-house, core team in-house, leverage the relationship with the PBM, and we've got ourselves north of 4 stars.
Yep.
It's fantastic. Paul, and Paul Van Ebers, again, CEO of Smart Story. Paul, you work with a lot of different healthcare organizations, plans, and thus different kinds of populations. So when it comes to, let's say, patients relying on specialty drugs, especially some of those newer patients, how are you thinking about, or how are you and your clients thinking about adherence and engagement for new patients that need costlier and more specialty drugs?
Yeah, thanks, Eric. Some of the same elements that Athena and Dan talked about apply here as well. We know specialty medications are just becoming a much bigger part of overall medication spend and overall healthcare costs. And any small change in adherence can really play a big role in the effectiveness of these drugs. And, the members who have specialty medications really have unique challenges uh, to adherence, and engagement really needs to be personalized to those needs. As we all know, people who are taking specialty drugs are facing usually pretty serious diseases, and the therapy can be complex and difficult to administer. Some of the patients don't have a full understanding of their disease or the medications, and often these drugs have side effects related to them, and require, fairly extensive assessments prior to doing refills. So we've worked with a major specialty pharmacy organization that, was facing a number of challenges around these drugs. The first was just onboarding patients and getting them to the patient portal, because unlike some more routine medications, it's generally not, it's generally delivered to their homes. They're not going to the pharmacy to pick it up. And so tracking shipments becomes important, and the portal is a major way for patients to do that. Also, they had a challenge in getting adequate education to the patients on the medication and the disease that the patient is facing. A lot of that educational material would be on.
Did you guys lose Paul?
He
Yes.
froze.
Wow. Okay. Yeah. So let me pick up. As Paul was talking about this story, it occurred to me, and it's funny because I was looking at, we always ask our clients to send us materials to help us research the topic and get better suited. And I was reading, they gave me a case study, and I'm pretty sure it was this one. If it's not, it's close. They just released it, and I'm gonna ask folks if they want a piece of it. So this will finish this story. I think it'll finish the story that Paul was about to tell. But it takes you through the end-to-end member journey, from personalization and patient reminders through the education and the patient dashboard. And what I think this big company, by the way, is doing. There's some really good nuggets about how all of you at the health plans can improve engagement and boost adherence. There's some screenshots and some charts, which everyone knows who listens to this show I'm a big fan of. How they use integrated immersive digital experiences grounded in this behavioral science. So if you skipped I would start right on page 3, just to save you some of the upfront stuff that's a little bit more promotional, and get into the results and how they do it. If people want me to send that to you right after the show, we'll do that. I'll put up a poll real quick and get that going. I also want to take on a couple of questions before we move on, because there's a bunch of really good ones, and I want to make sure I grab some of them quickly. So, Athena, coming back to you, who are the boots on the ground that are performing the work for the MTM program? Are they both the pharmacists and the pharmacy technicians?
Yes, so we rely on our pharmacy technicians to help do some of the behind the scenes research for a particular member, conduct outreach to schedule appointments, et cetera. The pharmacists are the ones actually completing the medication reviews and obviously doing some of that medication reconciliation and counseling with our members.
Great. Perfect. I'm gonna keep on plugging on, Paul. I think I covered you because we're gonna send people a case study, what I think is the story you were telling.
Yeah, I apologize, folks.
Okay.
We had a thunderstorm here, and apparently I lost internet, so I've signed
Well,
in using my personal hotspot. Hopefully this will work.
you sound great. We'll be back to you. I think it'll all work out. Appreciate you being so diligent and coming back to us. We're going to start covering now personalization at scale. And Athena, I'm going to stay with you right now and talk about the tens of thousands of cases that you guys see each week. So many different moving parts, so much different data inputs coming in. How do you ensure that outreach is both targeted, but you stay scalable?
Yeah, great question. I think it's something we continue to improve on and work towards is scale, especially as we're growing in our membership. Right now, our total Medicare Advantage population is close to 80,000 year to date, and including our standalone prescription drug plans, we're at over 120,000 lives. And so when we look at our adherence measures and our denominators year to date, we have about 150,000 cases of adherence that we're managing across all of our contracts. And that's really because members can be in multiple measures. We might have one member in all three of the adherence measures, for example. And so what we rely on is a weekly data file that gives us about 13,000 to 15,000 members that we need to actively manage that week. I rely on my quality managers within our pharmacy team to dole those cases out to the teams. And we use different metrics to determine, who we're going to outreach on any given week. And could be based on, when their refill is coming up, that deadline, that date, their historical adherence. So if we know that they're, historically a non-adherent member and might need more frequent touches to get them to be adherent. And then we also look at the overlap of members. So how many members are hitting all three of the adherence measures, for example. We really try to aim at targeting members about 2 to 4 weeks before that refill deadline, because we recognize that some members might need more touches, more outreaches to get them to fill. It also depends on, maybe they don't have refills left. And so we've got to work with the provider to issue a new prescription, or maybe that provider needs to see that member in their office before they issue that new prescription. And so we help kind of work behind the scenes to make some of that happen. And then we're leveraging real-time pharmacy claims data to guide our outreach. We do a lot of reconciliation between our actual claims information as well as the PDE data, which is the prescription drug event data that is, the standard by which CMS uses to ultimately calculate the measures. And so we do a lot of that recon as well. And so working, as I mentioned, collaboratively across the organization with our case managers, with our provider partners, we're really trying to achieve that scale in outreaching those members. But it's a work in progress, and some of the technology that we've kind of talked about with Dan and Paul, we're trying to begin to use some of that to help achieve that scale.
So it sounds one of the things that's striking me, and I know when we prepped, it didn't hit me, but now that I just listened to this in sort of formal format, you guys have really created a strict structure and process, and you're following it. That gives, and I know probably every organization is like, we have processes, but this seems to be really buttoned up. 13 to 15,000 members weekly, 2 to 4 weeks ahead of time, certain amount of people, certain amount of data sources, boom, 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 every week. Is that why you moved it in-house? Like, what wasn't working when you were not in-house and you were using outside partners?
So we didn't have, although we were pretty strong task managers, and we hold our vendors, all vendors accountable who work for us. However, it's different when you're in the weeds, looking at the data and being accountable yourselves to that performance. It's easy to sort of blame a vendor if you're not performing well, but you really don't have anyone else to blame but yourself if you're not doing it. So I think it's sort of upped the ante for us and really held us accountable. And so, the team takes it really seriously. seriously. And I think the other piece was bringing it in house and having the dedicated individuals. Like I have two managers who all they do day in and day out is stars. And that was a huge change versus, back when stars started in 2011 or 12, it was sort of off the side of everyone's desk. And now it's become sort of a core responsibility and role for the team.
And question for I'm going to go around the horn right here. I just want to take one more audience question in the Q&A module here. I'll start with you, Dan, just to give Athena a breath. When we're talking about data and what's driving behavior, what information would you like to know that you don't know with the current objective measures? Is there something that's like, wow, if there was one other thing we knew, we could be that much more effective?
Sure. How to get somebody to actually engage.
Okay.
I mean, that's the biggest barrier that we all face. And we happen to have maybe a little bit more transient, population because we're dealing with underserved populations. We end up with some homeless, folks like that bounce around. So honestly, having a viable engagement channel, I think we'll talk a little bit about it here in the future about how to engage, what the right channels are. And that might have even been one of the other questions, but, we're going to embrace all mechanisms. So from our perspective, like knowing where to meet the people, we might have the how solved and we might have the solutions and all the things ready to go. But, for that 10 to 15 or 20% of your population that you either end up with bad contact info for, they change it, don't update you, they move, they're in some, short-term extended stay situation and you don't know about it. It's just how to actually get them to engage in a way that you can help them.
Yeah, so if you want to engage me, suck me in with something about my golf game or something that's going on in the NFL. And I say that, you think I'm saying it tongue in cheek. I think the organizations that are able to get to know the interests outside of healthcare, outside of their wellness, and tie it into their wellness is going to take a giant leap in engagement. My 2 cents, not that it was asked to me. Athena, what about you guys over at Horizon? Like, what's the one piece of data that you may not have that you're looking for? And then I'll come to you, Paul, with the same question.
Yeah, I mean, I think I have to echo what Dan mentioned. I think, knowing where to meet members, what they prefer is key. But I do agree with your comment, Eric, about how do we connect with members and build the trust. What we try to do with our team is take a look at who called this member last year, right? Did we complete like a medication therapy, review with them last year, and try to have the same individual on the staff call that member back. We also, like I said, work with our case managers. So if they have a relationship already with a member, and just having that trust, and having them more actively engage with you, I think does go a long way. And so that is something that, is helpful.
Yeah, Paul, where are you on this? Because I'm sort of like I know I'm sort of the outsider here, but the more what are social drivers? Social drivers are essentially a cool social psycho term for what things people really care about more than their medicine, their doctor's appointments, right? When you are
Right.
living cold or you're low, and so I would say there's more than that, especially let's say for someone that isn't as, living under the gun every day, but let's say someone in a traditional Medicare population, if you want to talk to my dad and get his attention, give him an update on the Mets and then talk about his medication adherence. Probably give up some HIPAA information that he's a Mets fan, but whatever. So what about, how would you, what are you missing, Paul?
Yeah. An example that I think fits in here is a Medicare Advantage plan, a regional plan that we've worked with that, was in the 3 to 3.5 star rating based on across multiple products within their region. And their focus was really on medication adherence in stars. And one of the key things they just didn't know was what are the actual barriers that folks are facing. I think we all have from survey data, we all have some idea of what the top five, reasons for non-adherence are. But the plan really didn't know on an individual basis what those barriers were. And so A couple of things that they weren't able to do as effectively as they would like to do would be to, first of all, use their retail network to help them out to overcome some of these barriers. And in addition, the plan had a series of resources available to it, but it wasn't able to effectively deploy those resources without knowing what those barriers were. So where we came in was reaching out to the members where we're basically starting with a text, but then link them to a secure web environment where they can have an app-like experience without downloading an app to their phone. And in that environment, we could do a quick assessment of what the barriers were. Just tell us, here are the drugs that you're not adherent to. So it is personalized to that person. We notice you're not refilling these drugs. What are the barriers? And then from there, we're able to match them up with the health plan's resources that address that specific barrier. So, having a general idea of what the barriers are is great, but you've got to bring it down to that personal level and then address that specific barrier that that individual person is facing. And we were able to gather a lot of information from the members about the barriers that they were facing and then connect them to resources that the plan had. Dan mentioned some of those. If transportation is the problem, we were able to connect them to mail order or 90-day fill or home delivery from a local retail pharmacy. Or, about 1 in 5, almost 1 in 5 of these hard to reach patients actually said, I would like a phone call. And prior to this, the primary outreach was phone calls, but they just couldn't reach everybody through a phone call. So to know that this individual patient wants a phone call is a very valuable thing. It also acted as a nudge. About two-thirds of the people said, "Oh, thank you for reaching out. I will go get the prescription refilled." So there was a lot of value in gathering the specific barrier, connecting patients to the resource, and in addition, it just showed you were paying attention, and a lot of people just appreciated that and thought, "Okay, I'll go refill my medication."
It's great. Love that. This is you'll give me a good segue. I'm going to jump around a little bit, folks, but I just wanted to tell you a little bit more about the company that Paul represents because they're really innovative, and I think more of you need to know about them. Smart Story is a tech-enabled approach that combines what Paul just mentioned, secure, personalized approach to education, secure video, taking research-backed behavioral science that drives better clinical outcomes, but also creates just a better, more engaged, natural, consumer-centric experience. They're finding new ways to boost your overall drug adherence and improve that satisfaction amongst the consumers. So they play into caps as well. They use and like what Paul just mentioned, and I saw this because I had them put me through it, an app-like experience without having to download the app. I think that was is really impressive and important as well. So check them out at smartstory.com. Dan, we've been talking about personalization. Easy to really say, really hard to do, right? So you've not only you're at Zing, you've worked for a bunch of other health plans that people know and love and don't love, and you've lived through 10 times growth at Zing, right? You guys are growing really fast. So like how do you think about personalization at scale and how you guys are doing it at Zing?
That's a great question. So I kind of mentioned the right tools, if you will, before, and I think that's one of the best approaches that we've found is really that tool belt mentality. To the right people, I'll describe it as, Batman's always got the right gadget for the job, no matter what situation he's in, right? So we have to have those solutions. I have to have viable things. Someone in the chat or the Q&A had mentioned, just things like loneliness drive impact. Do I have a companionship type service solution where maybe that's the right thing that's going to help that, just a person that member can talk to? We want to use stories, we want to use examples. When we first launched this, kind of going back to Athena's point, when people stopped doing this off the side of their desks back in 13 and 14, Those were some of the early learnings that some people, we like to call them our frequent, callers, if you will. It's not our frequent flyers like hospitals, but they just wanted someone to talk to. And if you could just engage that person, right, you'd be able to make that impact, because all they wanted was someone that would spend some time with them. They were lonely. Now we've got creative solutions like in-home companions and virtual companions and things like that. And maybe that's that person's solution. What I would say is I actually want to talk out of the other side of my mouth for a minute. I think of personalization as the perception of personalization. Because at the end of the day, those tools are kind of like little micro one size fits all solutions. And you can't have 5 million solutions at your company, because it's not possible to, innovate to that level, and you're never going to get the funding to do it. So it's, how do we engage in a way that that engagement truly feels personalized, even though the 5 or 10 things that we're going to be doing behind the scenes are probably the same, to minor, degrees of separation, if you will, across the board. I might be getting 15 different people that I talk to in a day to do extended day supplies. But when I'm talking to Athena about it, my conversation with her is going to feel like it is just related to her, because we're spending the time and engaging with them. That survey vet that Paul was just talking about, that was actually one of the things that we did to keep up at scale recently, was to make sure that on every one of our conversations, we had almost like a needs assessment kind of survey at the front, like to really just personalize that conversation to the member and make sure that we weren't making assumptions about what their challenges were, their barriers were, and trying to force them into some cohort or some persona. We could get enough information from just 2 or 3 upfront kind of screening questions to then make a meaningful conversation for the rest of it. So I will come back to right tool in the tool belt is the first step. You have to give your people the tools to actually solve the problems, but then creating that perception that unique encounter is truly personalized to that person is going to be that difference maker. And I guess the last little piece of that is, it's as simple as listening to them for like communication preferences. I saw a question in the QA too. I'll answer that. It's every channel. If a person wants text message reminders and that's how they'll engage, you do it. If that person tells Paul's team they want a phone call, you make sure that they're on your call lists. If somebody likes email, you send email. If I can't get a hold of anybody, no matter what I try, I might FedEx them a letter and say, hey, you're not answering your phone or responding to anything. It's really urgent. You call us. Give me a call.
I love it. I mean, that's great. Perception of personalization, and focusing on solving that right barrier, having all the tools. I'm going to start calling you Bruce Wayne now. We should change you and Batman. And you're moderating too, because you're taking the questions from the Q&A. I mean, you are Batman. That was great. I'm trying to take notes here, folks. If you want a copy of my notes, which I sometimes offer up to the live participants, in about 7 minutes, you're going to get a survey asking for feedback and suggestions for topics for upcoming shows that we try planning with your feedback. That's your incentive. It's a 2 or 3 minute survey, and you get my unabridged B+ notes on everything that we covered in today's show. So take the time, do us the favor, 2 or 3 minutes. Just don't do it for the notes. Just do it because you want to be nice to us. But no, the notes are pretty good. So also, since I'm thinking about it, what we try to do more and more, this came from a survey, is register you for upcoming shows. We should probably do that with tech, but we're going to do it manually for you. We have 3 upcoming shows that we picked that are going to be relevant for everyone listening. Next week, we're covering something called missed data, missed dollars, and how member insights are allowing you to have less than efficient or perfect risk models. And so we're bringing in a CMO at Humana, head of data and engagement at Blue Cross Blue Shield of Tennessee, along with our sponsor, Acario Health, and they're going to share all kinds of bright spots there. We'd love for you to come to that. We also have a show on member engagement and how AI is helping with driving better engagement. And we're bringing on Highmark and Ovation and former Cigna exec and League to cover that. And finally, on August 28th, we're talking about AI and how you want to reduce your risk about bringing in AI, but what you can do about ROI measurements, and some companies that are really thinking through that from Blue Cross Blue Shield of Philadelphia, Independent Health, and Premera, and Blue Shield of California. So that's a big one that's coming up on the 28th. So if you want to register for any of those episodes, click on that poll, and my team will take care of it for you, so you don't have to go through the registration process again. And thanks again for just taking that survey. So Athena, let's stay on this topic. And well, no, let's go to member. When I say let's talk about engagement now. And how are you evolving your approach to member engagement to meet expectations? Right, Dan just teed you up when he said omni-channel, whatever it takes, phone calling, texting. How are you thinking about that, and what are you doing over in New Jersey?
Yeah, so similar approach for us as well. As a Blues plan, we were a bit slow with texting, but I think we've got it going now. And so we do leverage texting where we can. We also have had a big focus around the member experience in the last few years, and particularly around the pharmacy experience. We know in hearing from members and just anecdotal feedback as well as formal survey feedback that there is still a need for better understanding of the pharmacy benefit. How does it work? What happens at the pharmacy? And just working through those issues for members. And so we established last year a pharmacy concierge team, which really aimed at targeting that member experience. And so we're obviously seeing the effects of that in our measures as well. So we have real-time claims monitoring of our paid and rejected data. And we have a team that when we see those rejects at the point of sale, they're intervening behind the scenes to help resolve those rejects. So rather than a pharmacy waiting to, or a member waiting for the pharmacy to call the help desk, they are, or pharmacy help desk at the insurer, to resolve a claim at the pharmacy, our team is proactively outreaching and resolving those issues. So the member may not even know it's happening, but when they get to the pharmacy, it's taken care of. And so that has smoothed a lot of the process. They also help members proactively navigate when a drug might require prior authorization, in helping the member to understand what that means, what's required. Maybe there's a formulary alternative, a less expensive option. Even with Medicare members at the beginning of the year, when they have to go through transition fills, where they're switching benefits and maybe their drug isn't covered on our formulary. And so now they have to make a change. So our teams have been helping members through that. And that has really shown an improvement in our Part D CAPS measure scores. And obviously, as a side effect, it's improving adherence as well, because we're smoothing out the process and members are that much more able to remain adherent to their prescription. So that for us was a big game changer in the last year.
Great. So I like, so you're looking at scenario specific interventions using your concierge team of pharmacists to do it. And you're looking at historical data to avoid redundancies.
Yeah, so as I mentioned, part of the data that we get weekly, we take a look at and understand, how are these members historically non-adherent, and what did we try last year, right? And if they weren't adherent last year, what do we need to do differently this year? And I think Paul touched on this earlier, is understanding the barriers, right? So it's really important to leverage data we have and the conversations that we can have with members to understand where are we going wrong and what can we implement to improve the process. So do they need to sign up for refill reminders? Do we need to get them on a 90-day supply or extended day supply? Is transportation an issue? So need mail order. So it could be any number of those things, but yes, it's really understanding the history and then trying to do something different moving forward.
Right. Paul, I'm going to jump around a bit here because I know kind of getting tight on time. But I know you guys have done a lot of work in Medicare, and you've around engagement, scaling at engagement and at scale, and even looking at sort of the manual process of phone calls. So talk to us, tell me a story, like how I did that on the cup. Tell me a story about how a health plan maybe you're working with has kind of scaled their outreach while still making it personal and driving better engagement. You're on mute, Paul.
about that. So, talking about Medicare and scaling engagement, one of the things that Dan mentioned a little bit ago had to do with, using multiple methods of reaching out. And I think one of the things that we see is that, for example, IVR calls or a simple text message will often say, we'd like to talk to you about some important benefit in your health plan. And many members just don't know what the issue is, and therefore they don't respond to it. So one of the things that we try to do through our method of texting with a link is that it's possible for a person to find out very quickly what the issue is. Maybe the best way to resolve that is a phone call, but at least the person knows why they would want to engage in the phone call and how to go about accessing the person that they need to talk to. So, that's one of the ways that we try to leverage multiple ways of communication because we do agree that it's important to try to use all forms of communication. Sometimes a phone call is the very best way to reach out to someone, but sometimes a text with a link where someone can get a specific thing done can really help with that. You mentioned Medicare, but one of the problem areas that we've dealt with is Medicaid populations that can be harder to reach. For example, we worked with a Medicaid plan where over 80% of the members had a smartphone. We were able to identify that, but our initial reach to those folks was low. We were only able to deliver about 65% of the messages. And we had to investigate that to try to figure out why that problem was occurring. And essentially, what we found out was that about 30 to 40% of the phone numbers for these Medicaid members would change every year. And so, one of the things we had to do is just check and make sure that it's still a valid phone number and has not changed ownership in a short period of time. And then we also found that phones were either turned off because folks are trying to save minutes or data on limited plan phones, or they had mobile data turned off on the phone so that they could receive a text, but they couldn't open the link. So, in order to try to scale that and get through to those folks, we first of all worked on changing the time of day that we were reaching out to folks so that we would have a better chance of engaging someone during that period of time. And also just making sure that it was a valid phone number. What we found also was that this Medicaid population, once you get through to them, um, we found that it's best to be using simple messages. For example, we were offering members the opportunity to set up dosage reminders on their phone, and we found that members were starting to engage and then they would drop out. So we simplified the process to basically just say yes or no, would you like medication reminders? And we got much better engagement rate in the range of 20 to 25% when we simplified the process for those folks. So understanding the particular environment and the particular type of members that you're dealing with can really help you ramp up the level of engagement, depending on the population.
Oh, wow, there's a lot there. Not only understanding, but then having a process that's agile enough to shift, especially when you learn, like, geez, these people keep their phones off. Who would have thought? And be able to modify accordingly. I love that. I love that story. We got to do a write up on that. Uh, Dan, coming back to you, and one of my quotes that I learned when I was actually pledging my fraternity a long, long time ago. Fraternities teach education too. Is no man is an island, and I'm thinking like no company can really go it alone, right? No company is an island either. And like, how is Zing approached? When you talk about having a Batman approach to all the different social drivers and individualized situations that all your members have facing them. How have you approached partnerships to drive better outcomes for all these folks? Maybe provide us an example.
Yeah, great question. So back to the same vein earlier, no single, silver bullet in this. I found, and I'll even go back into my blues life, not too far in the distant past here. The most effective sort of solution I found is that kind of multi-pronged approach. It's not just unique communication channels. It's, to Athena's point, you got to have a good, strong core internal team and resources that are doing work. But that's still only going to get you so far. In some cases, you're going to have a member who their provider is the only person that they're going to listen to. They don't even care what the pharmacist says. They don't care what you say. Their doc is the person they'll listen to. Same thing with the pharmacist. Some people love their local pharmacist and they walk into the store. They refuse to move to mail order. They refuse to do 90-day supplies or anything else because they want to stop by and see Dr. Bob at the pharmacy, so they can have a conversation with them because that's a relationship that they've built. We found that sprinkling again solutions together, it's the combination of what you do internally and how you partner with the external partners. Probably the most profound example I can give is one that Zing is in the process of working toward, but actually really materialized in my previous life. We found that in our markets, most often, I think I heard Paul mention it, the local retail chain. The local retail chains actually, those true community-based solutions, like your local grocery and pharmacy combos, you think of all the different areas. Somebody's got, whether it's a Piggly Wiggly, a Giant, Kroger's, whatever it is. There's all these grocery store chains out there, the local, that have a pharmacy built in. And a lot of those places work with health plans because they're funneling a lot of dollars in there through things like your flexible spending technology cards. If you're an employer group, you might actually be the employer of record for insurance for that particular chain, etc. Um, and when you think about all those barriers that you're trying to overcome, you've still got local pharmacies on occasion that have some type of a zero or cheap $1, $2 type of discounted, refill that sort of encourages a person to just bypass their insurance. Not that that's the intent, but it happens. They think, oh, great. Yeah. If I just, swipe my local grocery card, I can get this for $2. In my mind, it's more expensive if I have to pay my co-insurance or something where it might actually be free. The partnership that I'd mentioned that was really successful is working with those local groups and actually meeting in person, looking through data, looking at the cohorts of the membership that were utilizing their pharmacy and sort of comparing notes. Hey, this is what we see. Why do you think these guys are more adherent than we are? And we'd find, either behavior patterns where, yeah, people were filling without using their insurance card, or, they were filling and it was a refill too soon. So the insurance rejected it, but they just decided to pay cash and were able to walk away with it, or some little, way to bypass the system. In doing that process together, we were able to put some upfront point of sale solutions in place to fix that. We were able to do creative messaging on things like receipts, just little simple reminders about, picking up your prescriptions or using the pharmacy, always use your insurance card. We found that some of those local and regionalized partners are really willing to partner with you when you're funneling dollars, funneling membership into their stores. It's a revenue model for them as well. Um, I mean, to the tune, I think, of what I had heard before, maybe from Athena's example, we saw, like overnight, 2 to 3 raw percentage point movement with large partners like that represent 30-40% of our membership base. They've got enough members that when you can find that type of a partner that's willing to engage at that point of sale, willing to stand up partnership events with you at their locations, things like that, you can really start to move the needle together. There are companies out there that specialize in doing things like presenting a point of sale technology solution for pharmacies where you can offer incentives as a health plan to get them to do councils and make sure someone's at an 80% fill by the end of the year as well. So I would argue that, aside from what you do telephonically, aside from how you partner with your PBM and the services that they offer, there are also those other types of solutions, whether they're your local community partners or the types of companies that work with the mom and pop, pharmacy shops and the local grocers and stuff to offer a more holistic solution. Adding those to your, string of tool belts or your sprinkling of solutions, is what we have found to be the most successful.
Love that. I was taking notes. I just so if I was going to summarize that like a blueprint for success from what I heard, you pick community-based local organizations that have aligned interests. The grocery store is a great example and resonates with me. Uh, you mentioned I love the receipt reminder marketing on the actual grocery receipt. Uh, leveraging the personalization. I'm assuming you're picking groceries with good, strong pharmacy teams and take the effort to get to know their customers. Tell me a little bit. You said something about upfront at the point of sale. I wasn't. Could you just break that down a bit and then talk one more and remind me flexible spending cards. Is that part of the blueprint as well?
Point of sale, there are some companies out there that offer technology solutions and they'll work across, pharmacy networks. They actually have things that will create a prompt or a pop-up whenever a member comes in to pick up a prescription or they, see prescriptions due in the system. Those types of prompts at that point of sale, if you will, the point of pharmacy encounter, it nudges that pharmacist to say, oh, wait, you're supposed to counsel, Dan about his adherence, or hey, Dan's 5 days overdue in picking this medication up. We need to talk to him and find out why. And you can use those types of technology solutions to offer incentives, because we can do provider incentives all day, we can do member incentives all day. Sorry, hit a button. The pharmacy space is a little bit harder to engage with. So that's one way to do that. Flexible spending, it's a mechanism that a lot of health plans are using to really capitalize in the supplemental benefit space, to try and, market their products in a way that address a lot of those socioeconomic issues we were talking about, social determinants. So people can use basically just call it like a healthcare credit card that'll have dollars loaded for things like healthy groceries or, maybe paying some of your utilities. A lot of plans will fund their reward and incentive programs onto those types of card solutions these days as well. So in those cases with your local retailers, if you're giving a healthy food benefit or you're giving dollars that a member's allowed to use for like, paying, picking up over the counter types of solutions, their aspirins, whatever, um, you know, you're funneling revenue into those local partners. So, the more you put out there on those wallets, if you will, you're helping drive revenue back in there. They want the person who's coming to buy their groceries to also fill their prescriptions there, or vice versa. The person that's already filling their prescriptions there, they want them using those grocery dollars in their shop.
Got it. Makes sense. I want to close with one final question. Also, my production team's yelling at me about this private event that I put in the chat. To give a verbal, if you guys are in a health plan and want to attend our September private meeting, check out the chat. It's on September 17th, 12 p.m. DM me and I'll add you to the calendar invite. Paul, final moments here. Talk us through, content-driven engagement and outline the real-world processes of testing, learning, and iterating, and what folks should write down here as they leave here. They want to sort of think about challenging their current content-driven engagement process.
Sure. So both Athena and Dan have really stressed the issue of understanding your members. Understanding their health conditions, their gaps in care, their barriers to care, their geographic location relative to other resources, and their communication preferences. So, it's really, really important to have that deep understanding of your members. The second point I would make is just multiple forms of communication. Dan just spent some time on retail networks and community organizations. It's great when you can get face-to-face interaction with people. When you can't, multiple other forms of outreach. Phone calls are terrific and are often a great way to interact with members, but they're often hard to accomplish. Portals and apps can have wonderful information, but it's sometimes hard to get the members to go to those locations. Email is great for more detailed information, but sometimes the response rates are a little bit lower. And then finally, text with a link to a secure web environment can deliver that app-like experience without the app. it's not a substitute for the other forms. It's an important additional channel, and it's reasonably inexpensive. So multiple forms of communication to reach those members. The next lesson is just keep it simple. One topic at a time, clear action steps. And if you can eliminate some of the engagement barriers, like, for example, with text, double opt-in, many health plans collect an opt-in at the time of enrollment. But if you ask for an opt-in again at the time you're communicating with them, it can really reduce engagement. And to the extent that you can reduce or minimize security validations within your overall security requirements, again, that can reduce engagement. And then the last thing is just constant measurement, feedback, and design. Data sharing on a weekly basis, weekly meetings to go over alternatives, and multiple small trials to test out what works.
Awesome stuff. I listen, all three of you, thank you so much for all the prep, the great job today. Really appreciate it. I applaud you all. For all of you listening and watching, thank you for tuning in. We do not take the hour you spend with us for granted. We work hard to make sure that the bright spots shared today inspire your thinking and enhance your overall approach to improving healthcare for all of us. We hope this was time well spent for all of you. A shout out to our producer of Akanda, Luangapai, did a great job as usual. And again, thanks to all of you and to our panel especially. We produced this show for all of you. Have a great day, everyone, and remember, this is your Bright Spots in Healthcare podcast. Take care, everyone. Great job, everyone.